it's essentially 100 mils per kg. That's a full shock dose. I mean, they say it's like 80 to 90, but 100 is a big, better number, right? So you have like a 15 kg dog come in, you can give him 1.5 liters. That's a full shock dose. But most of us will break it up into quarters or thirds so that we don't fluid overload the patient, and we'll assess after each time. The biggest thing, the most important thing is when you're trying to attack shock and treat it, is you need to deliver that bolus in less than 15 minutes. Because if you're not giving it, if you're giving it slowly over half an hour, it doesn't matter because most of the fluid is going into the interstitial space. So you want it in the blood vessels, right? Because what's it doing? It's trying to get blood to the organs so that our blood pressure raises and all of our organs get what it needs so that we don't have organs shutting down, like the kidneys and the intestines and the brain and the heart, like the things that need blood flow to them. So if you're giving a fluid bolus over an hour, 70% of that is not going to be in the vessels, and it's not going to do anything to try to counteract shock. So you need to give it very fast, less than 15 minutes. So typically with a dog, we count in our brains, the emergency doctors or internists or GPs or whoever. See, this is the total amount this dog would need, and then we're going to start giving it in allotments. So for example, we had Ranger who came in on Sunday who was a GDV, and he was in shock because he was quite affected by his stomach and his spleen torsing. And that dog was 40 kgs. So, because he was 90 pounds, he was 40 kgs. He could have how many liters of fluid?
9? No.
It's 100 mils per kg. 4 liters.
4.
Yep, there you go. And so we started out with 1 liter because that was a quarter of the shock dose. And he still was looking like his pulses were poor, his heart rate was extremely high. So we gave him another liter and treated him with some pain medications because pain is an additional factor in stabilizing patients in shock, for sure. And after that, everything sort of stabilized. His heart rate dropped, his breathing became easier, and his blood pressure normalized. For cats, classically, you get a 60 cc syringe and you give them that. So that's typically, most size cats, that's going to be a quarter of their shock dose, because cats are about half of what a dog is. So if you have like a 5 kg cat, you think if it was a dog, it would get 500 mils. So as a cat, it gets 250, and then a quarter of it is usually about 60. So typically, you can just grab a 60 cc syringe, pull it up, and give that to a cat when the cat's in shock. Colloids are like head starch or vet starch. We use those in cases when patients either A, aren't responding to crystalloids, B, we think that they aren't going to hold on to the normal fluids, or C, they come in such a state that we know that they're just going to need that. And the typical dose is 5 to 10 mils per kg, and usually the doctor will just say, like, I want this amount of the colloid of the head of starch, so.
So for the kitties, we do within 15 minutes too?
For head of starch?
No, or for the 60 cc.
Yeah, it's usually about 15 minutes. That's how we're going to actually see effect. The last type of fluid is hypertonic saline. We don't really use this very often. I think the only time that I frequently use hypertonic saline is in patients where they have head trauma. And what hypertonic saline does is it draws fluid out of the body and puts it into the blood vessels. And so you give it just a tiny volume, it goes into the blood vessels, and then it sucks fluid out from the cells and the interstitial, like, skin and connective tissue, to fill more fluid into the body. So the problem with that is that if we're giving it to an animal that's already dehydrated, we're sucking more fluid out of it into the vessels. So it's not good in those situations. So we don't use it very often, but I figured I'd just mention it because every once in a while we use it. So what are we going to do to monitor responses to see if we're fixing the shock situation?
Do the EKG machine?
We can do an EKG, or we can listen, right, to the heart rate to see if it's lowering or normalizing.
Blood pressures and
yeah. My only caveat to that is if we are extremely short-staffed, we don't need to try and struggle to get a blood pressure because we know this patient's in shock and blood pressure's not going to be normal. Once we're established and we're treating it, we can try and get a blood pressure, but I think that you guys utilizing your physical exam, like your skills to like listen to the heart rate, the pulse quality, mucous membranes, mentation, those things are going to say just as much as the blood pressure. I mean, blood pressure is a good number to have, but the patient comes in a state of shock, it's not going to have a good blood pressure. It's going to be hard to get, and it's going to take one person who could be doing something else away from intervening with this patient that needs to be saved. So usually when I'm down to like 1 or 2 people, I'm like, I don't care about the blood pressure. IV catheters, oxygen, fluids, whatever. Once we have a chance, let's get the blood pressure. So that's just my little soapbox moment. So that is essentially, 90% of the situations that we're going to be dealing with really critical emergencies. We're going to be intervening with fluids, we're going to be intervening with warming or cooling, we're going to be intervening with oxygen, and pain medications or sedation, and that right there is, in really critical cases, is what we're going to need. And then the specifics, once we get to the specifics, everything differentiates. But in the immediate time frame to prevent this patient from dying, that's typically what we're going to be doing. So to sort of demonstrate some of those scenarios, I put down a couple of common emergencies. So the first one, which I mentioned briefly, is the hemoabdomen, which I think is one that we see not infrequently. So how do they usually come in? Like, how do you guys see hemoabdomens come in?
Pale, panting. Sometimes they can't walk. Their belly is extended, like it's bloated.
Mm-hmm. What's like the classic things that I was saying when they're on the phone? It's just kind of quiet. Oh, here's my 11-year-old golden. He's just not really eating today. Yeah, it's, that's the classic for a mass. And then, of course, like there's the traumas and there's the toxin ingestions that are going to cause bleeding and things like that. But that's the classic. So they are hypovolemic, right? Meaning that their volume, the normal blood that's circulating in their body, is not normal, it's low. And that's what hypovolemic means, is that you're low on your blood volume. And so they are in shock because of that. So there's one really specific difference in managing these guys, these hemoabdomen guys, versus the other ones. And that's the way that we resuscitate them. Do you guys know what special difference we resuscitate these guys with? So it's called hypotensive resuscitation. So that means that we don't want to get them up to a normal blood pressure, because the thought is that if they're forming clots to stop the bleeding, if we get them up to a high or a too high normal blood pressure, they could actually stop that hemostasis and blow off the blood clots and start bleeding again. So we try to keep them somewhere around 80 or 90, usually, if we can, maybe 100 at the most, but we don't want them going up to 120, 150, anything up there, because if they get up that high, they're going to start bleeding again. And if they've stopped bleeding and we can keep them stable for surgery, that's ideal. So in those cases, I mean, I know that Susan talks about it, we definitely want them to be lower. So if we are having you guys resuscitate these patients with fluids, and all of a sudden you're getting a blood pressure of 150, 160, that's when you need to say, oh, excuse me, this is 150, 160, and then we're going to be like, oh no, stop resuscitating, we need to calm it down, and quiet the patient, give it some pain meds, things like that, to try to keep the blood pressure low. Sometimes we can auto-transfuse these guys too, to replace their blood. That usually only happens when it's trauma, which means that we're sterilely drawing blood out of the body cavity and giving it back to the patient. We don't do it very often with cancer unless there's no other blood products in the hospital, because the theory is that there's cancer cells that are circulating in the blood, and we're just going to be giving it into their bloodstream to like set up cancer everywhere. So, but if a patient is traumatized, we can collect it like we do with collecting blood from a donor into syringes that have an anticoagulant in them, and give it back to the patient to try to keep them stable until surgery. So the hemoabdomen is the classic hypovolemic. I mean, other cases where they're in that kind of shock are like severe vomiting diarrhea, like major HG, it's acute hemorrhagic diarrhea syndrome. That's what it's called now. So that's another situation like an Addisonian, a blocked kidney, trauma patients. So all of those definitely are hypovolemic shock, and we want to replace deficits with fluids. I mentioned the GDV. So how does the GDV typically present?
Back arch.
The GDV, the gastric torsion?
Distended abdomen. Oh.
Yeah. I mean, they can be, because they're doing the one thing, the really classic thing. So they're distended.
Trying to like throw up.
Yeah, the retching,
Yeah.
the horrifying retching, which if there wasn't a camera on me, I would like impersonate it right now, because it's like classic. No, forever, not gonna do that. It's like, hey guys, look at this video or on YouTube or whatever. You know,
They go
it's the
viral.
non-productive, violent retching to the point where the patient is like not even able to oxygenate itself appropriately. And then definitely distended abdomen, but not only that, but it's tympanic. It's like a drum. So when you touch the side, it sounds like a drum, and that's classic for torsion. Sometimes it's just a bloat, right? Just a gas bloat that hasn't twisted yet, which would be good because it doesn't have to go to surgery. But sometimes most of the time it's torsion. So I printed out a picture of it just so that you guys have reference. Just because that's how you diagnose it, is on the lateral x-ray, single lateral x-ray typically, and of course with your physical exam too. But that's it. It's the double bubble or the Popeye arm, one or the other. So
The
you
Popeye arm.
see the
Oh,
Popeye
Boxing glove.
arm? Boxing glove. Yeah, I haven't heard that. So this is obstructive shock because it's a space-occupying lesion or a mass in the abdomen. So this big swollen stomach is blocking the major blood vessels that go back to the heart. So all the blood that's in the hind legs and the abdomen is just sitting there, and it can't get back to the heart very well. And alternatively, the heart can't pump the blood back down there. And so you're giving them more fluid to give them a better ability to be able to get the blood through the body. And so it's not that the dog is low on blood volume because it's bleeding or because it's severely dehydrated. It's that this stomach is acting as an obstruction. It can't move one way or the other. Just like a foreign body obstruction, it's obstructing the blood flow. And so that's what we're trying to do by giving it fluid. And then if we have a big stomach like this, we will stick a big trocar into it and we will drain it while we're trying to get the dog into surgery into the side, so that we decrease that obstruction also. So those are the big things for intervention with obstructive shock. If you have, it's always going to be like reestablishing circulation and then removing the obstruction. So deflating the stomach, going to surgery, doing a pericardiocentesis where we pull blood out of the space around the heart, things like that. If it's tension pneumothorax where they're leaking air into their chest cavity, then you're putting a chest tube in. So you remove the obstruction and then you reestablish your body's ability to circulate. The last one that I mentioned already was heat stroke. So how do these guys typically come in? Have you guys seen heat strokes?
Yeah.
No? How do they? Well, you have. I'm sure you three.
Yeah. Yeah, I don't remember specifically.
Panting, yeah.
Temperatures up to the roofs.
Yeah, really high temperature.
Mucous membranes are bright red.
Yes, because what does your body do when you get too hot? That's why when you're running, you get really flushed. It's because your blood vessels dilate because they're trying to get rid of all that heat through increased exposure. So the more blood that's flowing to areas, the more you can get heat out of your body. So when your blood vessels dilate, it's getting more blood flowing to areas to release heat. And that's what it does in heat stroke. That's what it does when you work out really hard. That's what it does when, secondarily, interestingly, if you drink a whole bunch, it does the same thing. That's why you feel like flushed when you drink a lot, because the body does the same thing. So in heat stroke, just if you're looking at a patient, the gums are really, really dark red. That's why it's trying to get rid of that heat. And dogs can't sweat, right? So they don't have very many options. What else do we do to try to counteract? I mean, other than this, they may have respiratory distress and elevated heart rates. It's more common in brachycephalics. Unfortunately, they're not compatible with heat. So what do we do when these patients come in?
Try to decrease their temperature.
Yes, and what can we do to decrease their temperature?
Ice, wet towel.
Ice
like
is
ice
controversial,
packs.
so you definitely want to be careful with your ice, just because of
Can it drop too fast?
it can do that, and it can also affect the tissue a little bit more easily. So you want to make sure that if you are using ice, you definitely are wrapping it up and not laying it directly on the patient. So yeah, ice.
You just can wet the whole dog.
Water, that's the biggest thing, right? Pour water on the dog. Usually we're swimming in a lake by the end of these patients because we're just pouring water on them, and water's down us and on the ground and everywhere. So all the ways that you cool yourself off. What did you say?
I said everybody's wet.
Yeah, a fan, right? So circulating the air. So the different ways we can release heat by the water, by the air.
IV fluids.
IV fluids. Thank you. That's our fear. That's our like repeated theme for our shock patients, except for hearts we don't give that to. So fluids for sure. Some of these guys we have to anesthetize them and establish their airway because they're not able to breathe for LARPAR, brachycephalic, or even some patients where they're, you know, those really stressed out Labradors where they're just panting so heavily you just can't get them to calm down. Sometimes just taking that away from them and establishing an airway and just chilling them out is enough to get the body temperature to come down. They tend to be, like their heart rates tend to be really high. Sometimes the pulses will actually be really good on these guys because everything is dilated, so the blood flow is going like crazy through everything. So you'll actually see that the pulses can feel normal even though they are in state of shock. So there's the other thing when you're managing these guys and you're monitoring them. There's one other vital parameter you're going to want to warn your doctor when we're going through active cooling, and that is the body temperature. There's a point at which we always stop active cooling. Do you guys know what that temperature is?
103.
103. Yep. 103. So if we keep going, what's going to happen with these guys, because everything's dilated, everything's circulating, they're sucking everything in really quickly, they're going to go a reflex, hypothermia, exactly.
Really
So they're
cold.
going to get really cold, and then you're going to be doing the exact opposite and trying to warm the patient up. So oftentimes by the time they get to like 103.5, I'm stopping some of that water pouring and things like that and turning off the fan. And then once they get to 103, we start to dry them off and everything so that they don't become reflexive hypothermic. So the only other thing that I would mention about that is that that's not the only case of vasodilatory shock. I mean, another case of vasodilatory shock is anaphylaxis. It's where the foreign antigen, so the protein like the bee sting or the spider bite or peanut butter or whatever it is, causes the body to go into a massive reaction, and it causes the blood vessels to dilate most of the time. And so in those cases, oftentimes fluids and intervention like that isn't going to take care of that kind of a shock. So what have you seen doctors treat that with before?
Benadryl.
Steroids?
And one other thing.
Steroid.
People carry this around.
Oh, EpiPen.
Epi, yeah. So what is epinephrine? Epinephrine, it constricts, right? It's a pressor. And so we use that in these cases because oftentimes fluids and dexamethasone or steroid and Benadryl is not sufficient. I mean, it's counteracting the reaction, but the body's already gone into this vasodilation. And so usually you're going to have to give an epinephrine in true anaphylaxis. So that's just an example of one of these vasodilatory shocks where you really need to intervene a little bit more. So oftentimes if you come in with this patient who just had a vaccine and you're like, this patient just collapsed, usually the doctor's going to reach for the epi pretty quickly as we're establishing fluids and things like that, because that's going to be the biggest thing that counteracts it. It's going to like...
How do you give the
IV. Mm-hmm. So you always want to try and get an IV. And I mean, in people, they have the EpiPens, they just jam them into their legs, right? And you can get epi for dogs who have demonstrated that they do have anaphylaxis. It's just, EpiPens are really expensive, and so owners usually aren't going to be able to carry them around. So, oh, look at that. It's perfectly timed. I have 10 more minutes.
Do you want me to turn it off?
You can turn off. I'm just going to ask if anyone has any questions or anything. You don't have to feel like you need to ask a question. I'll leave these ones here in case somebody else comes.
For this one, if you said immediately like give IV fluids,
Mm-hmm.
like how is that supposed to help with the whole blood when it just stopped right here?
So if you think like if you're, for example, if I'm pushing down on like a hose and I only have it turned on to like a trigger